Most of you probably know most of these stuff that I am going to highlight today. But again, it is very important to go back to the basics. And so my topic of today's presentations will be decoding the chest X-ray, essentials for radiologic interpretation. So we are doing this presentation as a Society of Thoracic Radiologists mission to promote cardiothoracic imaging education worldwide. So we have mission for promoting this, and we do different lectures and worldwide in different places. And I'm honored to represent STR to this presentation for Cafe Rankin. So we know that the plain radiograph is two-dimensional, but the human body is not two-dimensional. Yeah. So main important questions while looking at the chest X-ray, we need to identify where do the normal 3D body structures project on a 2D chest X-ray image, and what structures are seen on chest X-ray. So when we look at, it's very basic. So we have these structures that we look at on chest X-ray. So we have the airways, we have the heart and vessels, we have the hilum, we have lungs, pleura, bones, and also the soft tissues. So coming to airways, it's pretty basic as I said before. So we have trachea, we have carina, we have mainstem bronchi, and we have the bronchus intermedius that often we see. So this is how we see it. So if you go back again, so this is the trachea, and you have carina where the trachea bifurcates. We have left and right main bronchus, and after the upper lobe bronchus, you call it right bronchus. In the right, you call it bronchus intermedius, which will give to middle and lower lobe bronchi. So if you look at coronal, so this is what correlates. So it is always important, particularly for the beginners, to look at the coronal images and correlate that with your X-ray. I always tell my students that it is easier to learn CT to find abnormalities, and it's very difficult on X-ray to find abnormalities. When we started reading X-rays, we didn't have such good quality CT scans. So for you guys, it's very fortunate. So you have CT scans. So you have whenever you have a CT scan for a patient with X-ray, correlates that with your coronal, and for lateral X-ray, correlate with sagittal. Then you'll understand X-ray easier and faster way. So look at this X-ray. So you see, like we talk about the anatomy. So the anatomy should be the trachea, carina, right and left main bronchus, but here you see another bronchus coming in from the trachea. So those are some of the variants that you may see, and this is what we call pig bronchus or bronchus, upper lobe bronchus from the main bronchus. Yeah, so these things can be seen on X-ray, and some of the stuff that we cannot see on X-ray is often difficult. Is this bronchus arising and blind ending from the right main bronchus? So this is called a cardiac bronchus. So when we look at this anatomy here, so if you follow the trachea, you see that paratracheal stripe. So that's a thin line along the trachea, and you should pay attention to this thin line when you are looking at an X-ray. So compared to this X-ray, if you look at that line, you see there is bulge here, and not necessarily that bulge. You also see the tracheal lumen narrowing and the contour abnormality. So this is certainly abnormal. So this is what the main idea with chest X-ray. You find the abnormality, then you will identify, do other investigations and make the diagnosis. But finding the abnormality may be difficult sometimes if you do not pay close attention. And that is why following these lines and stripes are very important. So in this case, this was a pancreatic cancer patient with metastasis. So this is another case where you see the widening here, and you see a lesion out there. So we'll not go in detail what this lesion is, but to see the abnormality is what is important. And it may be sometimes subtle, like this is the scout image from the CT. So there is widening out there in the left side, and this was a bronchogenic cyst out here. So coming to cardiovascular structures, so we have chambers, right, left, atria and ventricles. We have aorta, ascending arch and descending aorta. You have pulmonary arteries, and you have veins. So you see those structures when there is a lung interface. Okay, so you will have to have air containing lung to see those structures. So if you look at this chest X-ray, the right heart border, as you all probably know, is mainly the right atrium. So superior vena cava has some contribution to right heart border, but the primary structure that outlining the right heart border on plain radiograph is the right atrium, and then you have the inferior vena cava. So when you have enlargement of that border, so that is the right atrial enlargement. So for the left side, so after the right atrium, you have the right ventricle, but the right ventricle doesn't form any border on frontal chest radiograph because it lies just in front of you, and you see that the pulmonary valve lies way superior compared to other cardiac valves. So other cardiac valves will be somewhere around here, but the pulmonary valve is quite high compared to other cardiac valves. So after that, you have the pulmonary arteries going like that, and on the left side, the heart border that the pulmonary artery forms is just below the aortic arch. Okay, so we are going to right to left. So, and now if you have that enlarged, so that is the pulmonary arterial enlargement. You have different etiologies that causes pulmonary arterial enlargement. So this is quickly I'm pointing out here. So when you look at the bronchi, you have the trachea and right and left bronchi and upper and lower bronchi. So with the vascular relationship, in the left side, the bronchus is below the artery, so that is hip arterial bronchus, and on the right side is anterior to the artery, so that is eparterial bronchus. So if you look at on the plain X-ray, mainly what you see and probably important is the left upper lobe bronchus. So this left upper lobe bronchus is hip arterial, so that lies below the left pulmonary artery. So the right pulmonary artery is out there anteriorly, and this bronchus is the main one you see on X-ray. For detailed relationship, you will have to look at the CT scan to understand that hyperarterial and eparterial bronchial anatomy. So when you go further, so after the blood comes back from the lung with pulmonary veins, it goes to the left atrium. So left atrium has that projection that is called left atrial appendage. So that also forms the part of the left heart border. And then you have the left ventricle that forms main part of the left heart border. So you can see that on the right, it's mainly the right atrium, but on the left, you have multiple structures that form the heart border. So then you have aorta here, then aorta with great vessels, and then the aortic arch, and then you have the descending thoracic aorta. So if you look at here, the aortic arch outline is enlarged, so this is an aortic aneurysm. So this X-ray is very important, particularly I give importance particularly if the patient has a history of trauma. So what you see here is mediastinal widening, so there is widened appearance of this mediastinum, and also there is thickening of the left apical cap. So if you see this in a patient with trauma, you will have to rule out aortic injury, and this is the ill-defined appearance of the aortic arch with left apical cap and mediastinal widening. So this is a patient with aortic trauma. So when you look at it here, so you have the aortic arch and the pulmonary artery. So the gap between them, we call it aortopulmonary window. So that is the part of aortopulmonary window. So when you look at the heart borders, so you have the branch from the aorta, then aortic arch, then aortopulmonary window, and the pulmonary artery, then left atrial appendage, and then left ventricle. On the right side, you have the superior vena cava, right atrium, and part of inferior vena cava. And sometimes in elderly people, like in this radiograph, the aorta can be unfolded, and you have the aortic margin forming the right part of the heart border. So sometimes it can be reversed, like in this patient. So everything goes to the other side. So this is a situs inversus, where you see all the left-sided heart borders are on the right side. You have the gastric bubble here, and then if this patient has bronchiectasis, like in this case, and sinusitis, so you have the diagnosis of Cardiovascular. Okay, so coming to those anatomy and trying to figure out where these things are located. So this is an abnormality. So you see lying on the right side, probably mediastinal, because this is the way it is displacing the lung with acute angle, and also a lung abnormality like that will be very unlikely. So if it is mediastinal, then where it is localized? So as I said before, you see the margin of the cardiac structures only when there is a lung interface. So when you have an abnormality which is displacing the lung interface, you will not see that margin. So in this case, you see the abnormality and you see the pulmonary artery. So this is not in the middle mediastinum, and you do not see the right heart border. So it will have to be in the anterior mediastinum. So this is a lesion in the anterior mediastinum. So look at this lesion out here. This is on the left side of the mediastinum. You do not see the heart border in that location, and you see the pulmonary artery. So this is also in the anterior mediastinum. So if you look at this lesion out here, bubbly lesions overlying both hyla, and you do not see the cardiac margin in those areas, but you see the pulmonary arteries. So this will have to be in the anterior mediastinum. Okay. So coming to this lesion, quite similar to the first lesion you saw in the right side. So it's a mediastinal lesion extending mainly towards the right side. You see the cardiac border here. So it is not in the anterior mediastinum. Otherwise, that would have been obliterated. We call it Silhouette sign, whatever you call it. The main idea is to localize where the abnormality is. Yeah. And then you see the pulmonary artery. So it should not be in the middle mediastinum. So this is the hilum overlay. Okay. So you see the pulmonary artery. So it will have to be in the posterior mediastinum. So if you look at the lateral, you see it in the posterior mediastinum. If you look at here, you look at the bones, so you know that this is a diagnosis of extramedullary hematopoiesis. So that way you can identify where the lesion is localized. So that is why it is very important to understand the cardiac borders, where they are, and if it is obliterated, what location it is, and if it is not obliterated, what location it is. So most of the time, posterior mediastinal tumors, 90% of them will be neurogenic tumors, and in some cases like this, where you will have a few other differentials. So you can often make a differential diagnosis based on location, and that is why it is important to make that diagnosis based on your chest radiograph, because your next investigation may depend on your interpretation of the chest radiograph. So coming to this X-ray, so this is a very interesting X-ray for the beginners. Like, you will be thinking like, which side is abnormal? Is it the right side or it is the left side? Is the right side hyperlucent or the left side is less lucent? So if you look at the X-ray, the way you can differentiate looking at the borders. So if you look carefully, you do not see the left heart border. So that means there is some abnormalities going on that side rather than on the right side. So, and also if you look at carefully, you see the left hilum is stented. So this is not a normal appearance of the left hilum. So this is a typical appearance of left upper lobe collapse. So often you may see a lucency along the aortic arch, but that may not be always there. So this is your left upper lobe collapse. So if you look at that line here, so this is the fissure which is displaced because of the collapse of the whole left upper lobe. Okay. So this is most of the time malignancy until proven otherwise. Okay. So this is a very important X-ray to remember and see. It is not that difficult to identify which side is abnormal. And once you make that decision, you know that this is going to be most likely cancer. Okay. So here, the way you kind of understand, so this is the fissure, and in the CT sagittal reconstruction, you see that the left upper lobe is totally collapsed, and this is the line of the fissure. So if you do that from beginning, when you try to learn chest X-ray, you learn it with CT, it becomes very easy, and then you understand why you see those abnormalities. So that's the line. So coming to some other lines, so you have this line out here, so I'll go back there. So this line is your azygoesophageal line. So sometimes you have that bulging out there, you see along the line. So that is your dilated azygos vein. So that can be because of edema or some other stuff, but you can see that. And sometimes you see those lines. So these are paravertebral lines. Depending on exposure of the X-ray, you will see those lines. And then this is your azygoesophageal line. This is your aortic line. Okay, so and these are paratracheal stripes. So if you have the azygosophageal line displaced like that, this is a big hiatal hernia. So you do not need any other investigation. So you know that this will have to be a big hiatal hernia. So this is a displacement of that line out there. Okay, so the paravertebral line. So it is not always because of paravertebral pathology, like in this case. So you can see this is an esophageal mass actually which is displacing that line. Okay. And here you see abnormality which is displacing that line, lobulated margin. You do not see much on the lateral X-ray. So this is what I have noticed with this abnormality. So this is esophageal varices, okay? So which causes widening that you may not see on the lateral radiogram. So coming to this one here, pay attention and see that displaced line, paravertebral out there, and this is what typically you see with spondylodiscitis and paravertebral abscess. Since there are no tissue planes separating the mediastinal compartments, there are lesions that do not respect our approach to the mediastinum. Yeah, so these lesions tend to occupy more than one compartment, and they include like soft tissue or hyperdense content. If you see on CT, is infection or hemorrhage or mediastinal fibrosis or lung cancer or lymphoma. If it is fluid density, you have diagnosis of lymphangioma, particularly in pediatric age group, you can see them a lot. And then mediastinitis. Fat, you have liposarcoma, and then vascular, you have hemangioma. So the meaning here is that even if you are involving multiple compartments in the mediastinum, it may not be always malignancy. So that is what we worry in other body parts, but in mediastinum, the other things can also cause multiple compartment. So coming to very basic here, so you have the diaphragmatic outline, and then you have the costophrenic angle or costophrenic sulcus. You have cardiophrenic angle or cardiophrenic sulcus, so you'll have to pay attention because sometimes it gets obliterated. So here you have that obliteration, and there is obscuration of the heart border. You have see some expansion of the ribs, so there is fluid and collapse. So this is typical appearance of pleural effusion. So on lateral X-ray, you detect pleural effusion earlier compared to the frontal radiograph because it needs less fluid. So when the patient is standing in a peer radiograph, you need less fluid in the posterior costophrenic angle compared to lateral costophrenic angle. So, and this is how you detect pleural effusion. And this is also important to know, like sometimes when you have an air fluid level kind of encompassing the entire hemithorax. So on the right here, you see there is an air fluid level, entire hemithorax. Yeah, so you do not necessarily see the lung. So what is the difference here? So in this X-ray on our left, you see the rib spaces, the intercostal spaces are not widened compared to the other side. The mediastinum is not displaced. Here the mediastinum is somewhat displaced. So this is probably a patient with lobectomy or a pneumonectomy, where you see the cavity filled with air and fluid, and this is probably a patient with lung hydropneumothorax with collapsed lung, where the mediastinum is displaced. So you will have to know the history, or you will have to look at other features or clues to arrive at a diagnosis why you see the air fluid level. And sometimes it is difficult, I understand, but looking at those features like widening of intercostal spaces, displacement of mediastinum will help you make a diagnosis of hydropneumothorax causing displacement, then pneumonectomy with air fluid level. One thing to remember is that in any patients after pneumonectomy or lobectomy, the air should gradually decrease. If you see any follow-up X-ray where the air is increased, then you worry about bronchial dehiscence or bronchopleural fistula. So that is very important. Any post-lobectomy or pneumonectomy patient, you do not want to see increased air in the pleural space or soft tissues. Okay, so subcutaneous emphysema or pleural air should not increase after lobectomy or pneumonectomy. So this is something near the right cardiophrenic angle. And so there will be differentials. Yeah, it can be a pericardial cyst, it can be a lymph node. It should not be a Morgagni hernia. It's difficult to see the diaphragmatic outline in those cases. So, or it could be a cardiac lesion. So often for these kind of abnormalities, we end up doing CT. So in this case, this is a pericardial cyst, quite incidental. You do not have to do anything. You just arrest it. You don't have to do anything for this lesion. So one important thing to realize that in the frontal radiograph, we do not, we have both lower, upper, and middle lobe overlapping each other. So if you look at it here, so this is the horizontal fissure and this is the oblique fissure. See how high the lower lobe goes. So you see part of lower lobe here. So that is why if you have only the frontal X-ray and you do not have other signs like obliteration of heart border and other signs to indicate a particular lobe, you usually say upper, mid, or lower lung zones. Yeah. So and then that is the reason why you do it, unless you see a particular finding that that suggests that it is involvement of the anterior or posterior part of the lung. Okay, and if you have the lateral X-ray, then you can localize those abnormalities very easily. So this is probably you all know, very simple. There is air bronchogams, opacified lung, so there is pulling of the fissure, so there is some component of collapse, so it may be a consolidation collapse or it's just a collapse of the lung. But sometimes you may see this. You may see the fissure that is pulled up because of collapse is displaced down here, not necessarily pulled up like here. Okay, so in these cases, you worry about a mass lesion displacing the fissure out here, occluding the bronchus and causing collapse distally. So the distal part will pull the fissure because of the collapse, and the proximal part, because of the mass lesion, will push the fissure outward. So this is the golden S sign or reverse S sign, whatever you call it. So this is a suggestive of neoplasm out there. Okay. But careful sometimes in ICU patients because of positioning. You may apparently see some outward bulge, but if you have recent X-ray comparison and it was not there, then this is most likely not because of mass. I sometimes see that, so this is a patient after 1 day, it cleared. However, if you see that bulge in an outpatient coming without much symptoms or some symptoms of pneumonia, you should worry about the mass lesion and do necessary further investigation or short-term follow-up. So this was that patient where we saw that mass, and on CT and PET you can see central cancer. So sometimes lobar collapse, like this is a patient with total left upper lobe collapse and hyper-expanded left lower lobe that goes really high, may not look similar to the one we saw before. Okay, so it may not be all hyper dense or hypolucent, and like we saw in the total left upper lobe collapse. So I see this more frequently than the appearance we described before. So this was a patient with total left upper lobe collapse where left lower lobe is really hyperexpanded and went high, and there was a central malignancy. Okay. So now we'll go to the mediastinal reflections. So we looked at a few. So mediastinal lines, so they are thin, less than 1 millimeter in width, linear opacities that results from contact between two aerated structures. Okay, so lung, both sides of the lung, anteriorly and posteriorly, when they come in contact, they form anterior and posterior junction lines. And then for mediastinal stripes, we already talked about, like right and left vertical stripes, and they are bands that result from air outlining thicker intervening mediastinal structures, not like the junction line where the lungs are intervening. Okay, the mediastinal stripes present on PHS radiographs are those we already described. Then mediastinal interfaces, so or edges we call it, are produced by contact between aerated lung and adjacent mediastinal structures. So these are some of the mediastinal reflection. Right and left paraspinal lines, we looked at some examples. Azygoesophageal recess, we looked at an examples of hiatal hernia. That is the most common thing that displaces azygoesophageal recess. Aortic and pulmonary stripes, para-aortic line, and the cardiac borders. So here the anterior junction line, the black ones, and the posterior junction line, the white ones. Posterior junction line is usually vertical and goes higher, more than the clavicle, and this is anterior junction line is usually oblique and lower compared to posterior junction line. So this is the anterior junction line where the lung interface comes. You may not see all the time, okay? And this is the posterior junction line where the lung interface comes. So this is a patient with post-upper lobectomy where the anterior junction lung is displaced, where hyperinflated left lung goes retrosternally herniates and comes in contact with the right middle and lower lobes and giving you that line. So sometimes you may see the widening of the line because of fat, okay? So you may not see the anterior junction line, and sometimes it may be because of a lesion. So that's why it is very hard on chest X-ray to know whether it is a lesion or a fat displacing the anterior junction line. And most of the time it will be fat unless you see a clear reason to go for another investigation like CT. You usually ignore most of the time normally displaced anterior junction line. So coming to this is called cervicothoracic spine. So you have this lesion, mediastinal lesion, and you see the margin of the mediastinal lesion above the level of clavicle. So the posterior lung goes above the level of clavicle. The anterior lung is always below the level of clavicle. So to see the lesion, you will have to have lung. And if you do not see the lesion, that means the lung is not there. So if you have lung that outlines the lesion, that means this lesion will have to be posterior. And as I said, most of the time, posterior mediastinal lesions are neurogenic. So in this case, your next investigation will be a spine MR or a chest MR, whatever you prefer, and that is a neurogenic lesion on which I know. So, and this is called cervicothoracic sign. So if you see the margin of a lesion, because of the air outlining that lesion, that air will have to be in the posterior lung and the lesion will have to be in the posterior mediastinum, okay? So we'll look at some fine details or some few details about the lateral chest X-ray. It will take a lot of time to describe everything, but I'll go a few highlighted points. So first thing is the retrosternal space. So if you do not pay attention, you may miss the abnormality, and that is how I approach the lateral X-ray. So I'll go to retrosternal space, and I have three clear spaces. So this retrosternal space includes that part of the lung. And if you look at this X-ray, you do not see any abnormality, but on the lateral X-ray, you see there is an abnormality in the retrosternal area, and this is a lesion in the mediastinum. Sometimes it may be a lung lesion, so you'll have to look at that area. So similarly, you look at posterior to the trachea. So this is the posterior tracheal line. You have the aortic arch here, you have the anterior vertebral margin. So this triangular retrotracheal triangle is also called as a Ryder's triangle. So that is the area you are looking at. And if you have a lesion out there, like in this case, a big lung cancer hiding. So if you do not look at that area, you will not see that abnormality. So that is the point here. So you'll have to look at that area. So first you looked at retrosternal, then you looked at retrotracheal. So when you are in that area, so you see how thin that tracheal stripe is, yeah? So if you look at here, this patient has a thick tracheal stripe, okay? So this patient has some gastric pull-up for esophageal cancer, but that tracheal stripe compared to this one on our left is not normal. So you will have to look at that stripe and look for any thickening of that stripe, like in this case. So there may be different causes, but if you see the thickening, that means it is not normal, okay? So in this case, if you go a little lower, so there is a pleural effusion, ignore that. So if you get a little lower, you see something out there which is displacing the air-filled esophagus. So between the trachea and esophagus, if you see an abnormality, and if it is a vascular abnormality, there is only one diagnosis, okay? So that abnormality, so if you see that CT, sagittal reconstruction, so this is a vascular abnormality. So there is only one vessel that crosses between trachea and esophagus, which is a developmental anomaly. So you guys can think about it. And if you do not know it, then remember that is the vessel that crosses. is the left pulmonary artery that arises from the right pulmonary artery. So it goes between trachea and esophagus. So this is called pulmonary sling. So this is the only abnormality that causes between trachea and esophagus. All other vascular abnormality, right-sided arch, double arch, aberrant left subclavian artery, all crosses posterior to the esophagus. Okay, so this is one diagnosis that you can even make on plain radiography if we pay attention to that area. So coming to the another area that I pay attention is the retrocardiac. Okay, so we looked at retrosternal, we looked at retrotracheal or writer's triangle, and we are coming to retrocardiac. So this is the area we are looking at on the frontal X-ray. It may be very hard to look at that area, and in the lateral X-ray, if you pay attention, you see that abnormality in the retrocardiac area, and that is again a cancer out there sitting. Yeah, so. And the other thing that we look at on lateral X-ray is the infrahilar triangle. Okay, so this is the triangular lucency, not fat, triangular lucency out there, infrahilar location. So whenever you have hilar enlargement, like here, you see this hilar enlargement compared to the other side, you look at that infrahilar area. So if it is obliterated, then this is enlarged lymph nodes. Okay, so this is how you can detect that. Okay, and most of the time when you have that hilar enlargement and that is not obliterated, that is because of enlarged pulmonary artery. So that is an important part to look at, the infrahilar triangle. Okay, so on the lateral X-ray. So coming to another important thing to look at on plain radiograph is pneumothorax, so that you all can make a diagnosis. Yeah, so when you have air in the pleural space, you have the collapsed lung, this is pneumothorax. But look at this pneumothorax out here. The lung which is collapsing is going towards the hilum. So the lung has an inherent tendency to collapse towards the hilum. When you lose the negative intrapleural pressure, the lung will collapse. So the negative intrapleural pressure actually keeps the lung inflated. But here in this collapsed lung, you see it is not going towards the hilum. So it is falling along the diaphragm. Even with the chest tube, this pleural pneumothorax is still big. Okay, so when you have a fallen lung or the lung falls down along the hemidiaphragm, and you also have a chest tube where the pneumothorax is not decreasing, you will have to worry about bronchial injury, tracheobronchial injury. Okay, so in a patient with trauma, if you see a pneumothorax large like that, you call it tension pneumothorax because the mediastinal is displaced. You worry about venous compression and patient going to cardiac arrest. However, when you see a lung which is not going to the hilum, you will have to raise the possibility of tracheobronchial injury. Post-surgical patients, it will be tracheobronchial air leak, so you'll have to pay attention to that, and that is very important, and that's called fallen lung sign. Okay, so that indicates tracheobronchial injury. So coming to another abnormality that we see on radiograph. So this is a big pneumothorax with a collapsed lung going towards the hilum. You took the pneumothorax out, drained it in 2 hours after chest tube. You see there is opacification of the lung. Yeah, so there is opacification of the lung. You see some interstitial, some airspace opacities. So this is what we call as re-expansion pulmonary edema. Yeah, so diffuse consolidation you see there, and there you see the pleural drain. So when we followed this patient, 24 hours later, you see the lung is better. So this is what you call as re-expansion pulmonary edema. Okay. So coming to another abnormality. So if you look at these heart borders, you see on the right heart border, there is something not normal. So if you look at the normal structures, you know the normal structures, you see that this is not normal. Okay. And you know that on the right side, if you see something abnormal like that and the patient is asymptomatic, you worry about abnormal pulmonary venous return. Yeah, so you look at all the outlines, line and stripe, and you see that this is not something that should be there. Okay, and also you see there is some planting of the costophrenic angle, so there may be a small amount of fluid. So that's how you look at the plain X-ray. So in this particular case, there is this thick linear structures going from the right lung to the hemidiaphragm, and then you do the CT, you see that anomalous pulmonary venous return draining into the inferior vena cava. Okay, you have a lot of science that describes those. That is not very important, but what is important is that you identify that this is not normal, and then you can go to the next step to make a diagnosis. Then the terminologies that we use on chest X-ray. So you say opacity when it is white. You say consolidation, like in this case, where you see a large area of opacification and some fluffy, irregular, round to oval opacities which are trying to coalesce. So if you see opacities like that, you call it airspace opacity. Okay, so airspace opacity, interstitial opacity, those if you can characterize on chest X-ray, then you will able to make a diagnosis. So in this patient, if this is developing acutely, the fluffy, irregular, round to oval opacities, they try to coalesce. So that is your airspace opacity. So there is something filling within the airways. So what can fill acutely? It will be fluid like edema, pus like pneumonia, hemorrhage in pulmonary hemorrhage, or food in aspiration. So you can make a differential based on how you see the opacity, and this is a case of pneumonia that we had presented with pneumonia. And then sometimes you see abnormalities like this. So what do you call it? This abnormality. So this is, some people will say hazy opacity, some people will say ill-defined opacity, but you see some linear opacities out there. So there is some interstitial thickening with ill-defined opacities or hazy opacities in both lower lungs, and that you see here what we call crazy paving typical. So you have ground glass opacities with interstitial thickening. So this can be seen with a lot of different cases. In this case, it was a patient with pulmonary hemorrhage. Then comes the nodules. So how do you characterize the nodule? So when you have discrete nodules like that, multiple tiny, not in specific lung zones, distributed everywhere on chest radiograph, and they are not coalescing, because when they are alveolar like that, they will try to coalesce and form consolidation, but when they are discrete like that, they are probably interstitial and they are miliary. So you guys probably see a lot of miliary nodules in India. So in this case, this was a case of blastomycosis. And coming to this abnormality on chest X-ray, you see all the linear opacities out here in the lower lungs. So there is some architectural distortion that you can see nicely on the chest X-ray, and these are interstitial opacities with some architectural distortion. Can you make a diagnosis of interstitial lung disease? Probably not on chest X-ray, yeah, but still you can suggest that this involves the peripheral lower lobe of the lung, and interstitial, there is architectural distortion, probably some interstitial fibrosis is going on. Then if you look carefully, you see that opacity out here, which has kind of a mass-like opacity with some central opacity with peripheral lucency, so AR crescent sign and stuff like that described. But if you see that abnormality, so you know that there is a cavitary process out there filling with a soft tissue opacity structure inside with some air outlining. So this may be an aspergilloma in a cavity. Most likely that will be what it will be in these patients with interstitial lung fibrosis, but sometimes you can see invasive aspergillosis with surrounding ischemia. But those stuffs are mostly you make a diagnosis on CT scan, but seeing the abnormality and trying to characterize it on X-ray is something important. So in this case, this was a case of PYP, and you have that aspergilloma sitting in that cavity. So then talking about abnormalities, so like you when you know the anatomy here, so this is a patient with gastric tube evaluation, so you know that this should be the course of bronchi. Yeah, so this goes through the trachea, right main bronchus, and goes quite to the midline. So like you need some expertise to put it in the trachea, and as the right main bronchus is vertical, so you will see it is often going to the right side. So this is another example where it went to the bronchus. So you can have sometimes the gastric tube going to the bronchi, and sometimes even I have seen cases where it goes to the left-sided bronchus. So that's crazy. So what I would say here, so I do not have um, many other slides because I tried to keep it concise, and I could have included a lot of different stuff, can go way over more than 2 hours, but I thought this will give you some idea how to look at the chest X-ray, what are the normal structures to look at, and how to identify abnormality, and then also the location of abnormality, and sometimes try to characterize those abnormality by giving different terminologies like airspace opacities, interstitial opacities, and also identify structures going to abnormal location, like in these chest X-rays where you see the gastric tube is going to the bronchial tree. I would also suggest you all to look at Fleissner Society Glossary of Terms for Thoracic Imaging. This is very helpful document. You may not always agree to all the terminologies described here, and sometimes it is very difficult to use terminologies specifically described here. Like I have seen a lot of my colleagues using airspace opacity to describe linear atelectasis. So that is what not Fleissner Glossary of Terms says. So airspace opacities are filling of airways, so those will be more round or oval opacities rather than linear. However, that is not always accepted. Not everybody uses chest terminologies like that, but looking at this document will help you to understand the terminologies and why they are used like that, and how those terminologies will help you making a diagnosis or suggesting the next investigation. That is why this document is very important. Please look at this and try to understand why we say interstitial opacity, airspace opacity, ground glass opacity, consolidation, and all the terminologies that we use in our thoracic imaging. Thank you so much. So this is all I have. So I'm here to answer any questions if you have.
Thank you, sir, for that extensive and amazing session. You made chest X-ray read easy for all of us. It was lovely, and I'm glad that we could invite you for our 800th webinar. There are quite a few questions in the Q&A. I'll just put them across one by one, and you can also go through them as I put across. It's in the Q&A section, sir.
Okay, stop sharing. Okay.
Yes, sir. So the first question is how to differentiate between pleural effusion and empyema on chest X-ray. I mean, can we do it actually?
Yeah, so like when we started doing chest X-ray, like early days when I started my residency in India, in Assam, like we had only one CT scan. So we tried to do our best with chest X-ray to make diagnosis, like whether there's empyema or whether it is only pleural effusion or hemothorax. We used to read all those Simons and Felsen textbooks and trying to find that the points. But most of the time you cannot. So as you said, so you rightfully said, we cannot. So that's how where we stand now. Unless you correlate it with clinical information. Yeah, so you have the clinical information of a patient with fever, and then you see a large area of consolidation, then you can think about that pleural effusion is probably due to empyema rather than parapneumonic, just pleural fluid. But still you cannot. So you will have to do a CT or pleural fluid analysis. So there are some criteria you can use, and people will talk about those. You will see that on textbooks. But on all practical purposes, I will say this is not helpful. So we never try to make a diagnosis of empyema from only chest X-ray. So if you have a patient with trauma, multiple rib fractures, and you see pleural effusion, you can call it hemothorax. Yeah. So like those are the ways you can do it. But otherwise, I do not think there is any available radiographic reliable findings that will help me say that this is empyema rather than simple pleural effusion.
Yeah, thank you. There are quite a few people who are putting it questions in the chat box. Please put them in the Q&A. We won't be going through the chat box for the same. So the next question is how to identify a lesion involving both anterior and middle mediastinum simultaneously.
Yeah, so that's the thing. So you like the straightforward answer is that you will obliterate the lung that is outlining the anterior and middle structures. So the anterior structure is your heart, so you will not see the heart border. And the middle structure is the pulmonary artery. So you see the pulmonary artery because you have the lung outlining that. So if you do not see those, then you know that it is at least involving the anterior and middle part of the mediastinum. You do not know the posterior. Still, it may be involving posterior, but then you will have to think like what kind of abnormality it will be. Yeah. So most of the time, with involvement of multiple compartment, that will be like will present with symptoms of infection. Then you think about mediastinalitis. Patient has superior vena cava obstruction, or then you think about mediastinal fibrosis or neoplasm infiltrating. So the straightforward answer is that you will not see the margin of the heart border and the pulmonary artery. Heart border is quite reliable, but the pulmonary artery is not always reliable. But if you do not see those two, you know that at least the anterior and middle mediastinum are involved.
Thank you, sir. Mm. The next question is, in the chest X-ray of left upper lobe collapse that you had shown, is there any way we could have pointed that such a large hilar mass is there, which was not obviously seen on the X-ray?
Yeah, so that's exactly what, if I missed it, I should have said that. So I think there is a big, large left hilar mass, and that is what I have seen like throughout my practice till now. I have seen so many cases of collapse that may not be that obvious. That is why whenever you look at a chest X-ray and you see difference in lucency of both sides, you will have to be careful. You will have to figure out why that lucency difference is. Is it because of patient's rotation? So for rotations, whenever you look at a chest X-ray or any X-ray, you look at the most anterior and most posterior structure. For the chest X-ray, you look at the medial end of clavicle and the spinous process. So if the distance between the spinous process and medial end of clavicle is similar, then patient is not rotated. If it is one way more than the other, then the patient is rotated. So the rotation can also change the lucency of the lung, then mastectomy and other stuff. But if you do not have those reasons and you see that one lung is opaque than the other, then you will have to pay real attention, because big things can be hidden on chest X-ray. A big pleural effusion, you may see only minor blunting of the costopenic angle if it is really subpulmonary, yeah? And you may not see the lateral tenting that we often describe, and that's why I didn't include it. So many cases I have seen with big pleural effusion hiding below the diaphragm, where you do not see the lateral tenting. So those are the stuffs that I could have included, a lot of stuffs to include. I choose some which are very important, and your point is really valid. There was a big mess, we didn't see it, only we saw the indirect evidence. That is the collapse because of the mass. And the collapse is also so hard to see. If the patient was not taking a deep breath, it would have been really difficult to see that collapse. But once you pay more attention, you will look at carefully, and you will know that there is a mass hidden out there.
Yeah, thank you, sir. The next is, when should we use the terms haziness and opacity on chest X-ray and CT? Yeah.
Yeah, so when we talk about terminology, so the language of radiology, I do a presentation for our medical student initially when they come to medical school. So we have specific terminology. Yeah, so for chest X-ray, we either say opacity, lucency. CT scan, we say attenuation or density, and MRI, we say intensity, and ultrasound, we say echogenicity. So density is the term we should use for CT scan, not for X-ray. But you will see we often use them interchangeably. Haziness is something not described by Flessner terminology. They say that you should able to make a commitment, like this is either alveolar opacity or interstitial opacity, but you cannot always. So that's why those terms are, although vague, we use it vaguely. So we say haziness over the hemithorax. So if I have a layering pleural effusion and the patient is supine and you are doing an anterior-posterior chest radiograph, what you will see the fluid lying behind the lung. So there is increased haziness, which may be a little bit more kind of dense or opaque, whatever you call it, more white towards the lower part of the lung and less white towards the upper part of the lung. So I'll use the term graded haziness. So it is a graded haziness from top to bottom of our right hemithorax, and I think there is a fluid layering along the lung posteriorly in the right hemithorax. So those terms are not specific terms. The people are using them all the time. So ultimately, your idea is to can you give a differential? So we have some dictation guideline for my students in my section, like our cardiothoracic section. When they come in, they cannot put in their impression of a chest X-ray that the consolidation in the lung. So they will have to give a differential. So if they have to look at clinically if the patient is presenting like pneumonia, so consolidation suggesting pneumonia, something like that. So we try real hard to make a diagnosis. So then it becomes really irrelevant how you describe the chest X-ray. So even if you say haziness, ill-defined opacity, and then you try to make a diagnosis or try to suggest the next step, then probably doesn't matter that much, but try to stick to saying airspace opacity or interstitial opacity whenever you can. Otherwise, you will have to use the terms haziness, ill-defined opacity. Do you use ground glass opacity on chest X-ray? Yeah, so many people, they do it, but there is no actually clear definition of ground glass opacity on chest X-ray. It is on CT, yeah. So in CT, if you have a dense area that is obliterating the vascular margin, that is consolidation. If it is not obliterating the vascular margin, that is ground glass opacity. But we do not have that definition for chest X-ray, but still sometimes we use it. But I do not think it really matters as long as you are pointing for a diagnosis or a differential or suggesting the next investigation.
Yeah, thank you, sir. On a similar line, do we use ground glass on radiograph or it's mainly a CT terminology?
Yeah, I probably already answered it. Yeah, so ground glass is, so what is ground glass? So I have little time, so I'll just quickly highlight. So what is ground glass? So ground glass opacity is partial obliteration of airways. Yeah, so consolidation is complete filling of the airways. So you see consolidation when it fills, like four stops mainly, pus, blood, fluid, and food. So, and when you have partial obliteration. Why I say obliteration? Because initially when we started describing ground glass opacities, we thought it is all alveolar opacity. Because of partial filling of the alveoli, you see ground glass opacity. But you see ground glass opacities because of interstitial abnormality too. So interstitial abnormality can displace the air from the alveoli and partially obliterate the air. So when you do not have complete obliteration, you see ground glass opacities. So that can be because of interstitial or alveolar problems. And you describe with CT. So is it the right term to describe on X-ray? Theoretically, it is not. But if you are using it and then in the impression you are saying a differential, suggesting a diagnosis, suggesting next line of investigation, suggesting a specific clinical correlation, then it probably doesn't matter. You can use it. I have seen a lot of people nowadays using it. And we had that discussion in last Rank and Ray conference. And a lot of old people who wrote textbooks on chest X-ray, they also nowadays agree that you can use these terms vaguely sometimes because you read so many X-rays. Yeah. So, as long as you are doing one of those, you can use it.
Thank you, sir. The next question is about subpulmonic effusion. Does meniscus sign have a role, and how to differentiate pleural effusion from a subpulmonic effusion?
Yeah, so free pleural effusion from subpulmonic effusion. Yeah, so that lateral peaking of the diaphragm is something classically described with subpulmonary effusion. This I see when the patient is kind of standing in a PA, classic PA X-ray. But most of the time, those subpulmonic effusion happens in an ICU patient and localized below the diaphragm. And I do not often see that sign. So if you see that sign, it is helpful. if you do not see that sign, that doesn't mean that you do not have a subpulmonary effusion. It is very hard to detect subpulmonary effusion, particularly in an AP radiograph, portable AP radiograph. Um, but increased haziness may help you diagnose elevation of the hemidiaphragm, that may be with or without lateral peaking, and often you will see some free fluid. It may not. It is not always subpulmonic fluid. Often you will see some blunting of the costophrenic angle. So you will have to put all of those steps together to make a subpulmonic effusion. But having said that, we have missed big subpulmonary fluid collection where we thought this is a small pleural effusion on chest X-ray, and we did CT and saw that, and it's really hard to make the diagnosis. So if you see typical meniscus or lateral peaking, then you make the diagnosis. Otherwise, it is very hard to make the diagnosis.
Yeah, thank you, sir. The next question is, in many cases, there is straightening of the left heart border without any obvious pathology or signs. Does this need any further evaluation, or it is a normal variant finding?
So the left heart border, yeah. So left heart border straightening. So most of the time I see in patients with hyperlucent or emphysematous lungs. So and otherwise, if there is nothing to evaluate, I do not pay that much attention. Yeah. So often, like when you are saying straightening, you are mainly saying for the left ventricle and the left atrial part of the border, but the aortic arch is often in those cases you will see the aortic arch. You will it's not that that will be also flattened. So personally I do not give that much importance unless I see any secondary evidence of left lower lobe collapse and stuffs like that.
Thank you, sir. How to objectively differentiate airspace versus interstitial opacity only on chest X-ray, especially in the absence of air bronchograms?
Yeah, so look at that Flesner glossary of terms that will help you understand. But the airspace opacities, when we say specifically, like you using the Flesner glossary of term, airspace opacities are filling of airways, either with fluid, fast, blood, or food. So when you have filling of airways, they appear like round to oval, often fluffy, irregular, and they try to coalesce and form consolidation. Okay, so that's how it is described. So you can see that. So like that one example I showed where you saw some round to oval opacities and some areas are more nodular consolidative opacity. So if you see that pattern together, you know that this is airspace opacity. So what do you want to differentiate? Airspace opacity and from interstitial opacity. Yeah, so if you have airspace opacity like consolidative opacity with volume loss, like secondary evidence of volume loss, like visceral displacement, hilar pull-up, or diaphragmatic elevation, you know that there is some component of collapse. If you see air bronchoscopies, you know this is consolidation. Then you are trying to differentiate it from interstitial opacity, which will be mostly linear, thin linear, yeah. So and specific locations, if it is because of edema, like your curly lines you see perihilar or along the right lower lateral chest. So and do you call atelectasis airspace opacity? Yeah, so those are airspace opacity because of less air in the airspaces. But Plessner doesn't suggest that you call atelectasis airspace opacity. I often describe them as linear opacities, maybe atelectasis or scarring. So I think you can detect airspace opacity when you see it classically. You do not need to have air bronchogram. When you talk about consolidation, then air bronchogram or fluid bronchogram helps you make a diagnosis of consolidation with or without volume loss.
Thank you, sir. The next question is, can you share your experience about reactivation of tuberculosis versus old COX? I'm not sure if that's visible on X-ray and to what extent, but yeah, whatever experience you think.
Yeah, like I think with X-ray it will be really hard. Yeah, and you all probably have more experience now. For I'm here for long time in US now. We do not see that much of TB out here. But from my experience, I had a good years of experience in India. I think from X-ray only, yeah, it will be hard to say that this is reactivation TB than not. I think, yeah. We can talk about all the findings that we see with TB. What makes it more active and what makes it more less or not active TB, like calcification. Even calcification can harbor active TB. Yeah, so it will be very hard to make a diagnosis of reactivation TB looking at chest X-ray only.
Yeah, thank you, sir. So now there are a few questions with the cases that you have shown. The first one is how to differentiate opacity from pneumonectomy and pleural effusion in that radiograph that you had shown.
So I had two radiographs together. Yeah. So one was on my left was the pneumonectomy, and on the right was the pleural effusion with collapse. So hydropneumothorax with collapse. So in pneumonectomy, you will not have widening of the intercostal spaces because you remove the lung. Now the space is filled with air fluid level, and that is usually smaller than the volume of the lung. It may be similar to the volume of the lung, or most of the time what we see, it is smaller than the volume of the lung. So in that case, you will not have expansion to cause widening of the intercostal space, and similarly, your mediastinum should come towards that side rather than displaced towards opposite side. And when you have air fluid level, that big collection with collapse of the lung, your intercostal spaces will widen and you will push the mediastinum towards the right side. So that is how you differentiate, and then you can look for surgical sutures and stuff like that.
Thank you, sir. The next is there any difference between hilum overlay and underlay sign?
We do not talk about those signs anymore. I know we talked about when we started learning chest X-ray. I do not use them. So my main idea is, do I see the pulmonary arteries out there? If I see it, then I know that the abnormalities should not be in the middle mediastinum. If I do not see it, that means the abnormality still may not be in the middle mediastinum. So sometimes I may not see the pulmonary artery normally. So that's all I know. I do not go in detail about those signs because those are not helpful. I do not think they do not help a lot.
Yeah, last question, sir. Can you show the eparterial versus hyparterial bronchus again?
Okay, so let me then share again. But the thing is that this is mostly for, let me go back. So this is mostly for CT scan. Okay, so we go back. It's mostly for, let me, why it is not, okay. So it is mostly for CT scan. So that is why I didn't go that far. So let me try to go to that slide. And it is very important for CT scans, particularly when you are imaging for congenital abnormalities. So we do a lot of congenital cardiac disease. So my cardiothoracic section takes care of a lot of congenital heart disease. So in those cases, we look at that very carefully. So for the sidedness of the lung, yeah, so you can have right-sidedness or the left-sidedness, and that will give you different differentials, and some associated congenital anomalies are common in one side compared to the other side. So for that, you can look at the fissures. Okay, so you know that on the right side you have the oblique fissure and the horizontal fissure and 3 lobes. On the left side you have 2 fissure. Only 1 fissure, oblique fissure. So you have upper and lower lobe. So if you see 3 fissures, then you can think that, okay, this is a right-sided morphology lung in the left side. Then you will have some association, like when you talk about heterotaxis syndrome, like it will have probably asplenia, and other abnormalities associated with that heterotaxy. Yeah, and if you have bilateral left-sided morphology lung, then you have polysplenia and other associated abnormalities. But that is not always helpful, because you often have accessory fissures without, like you have two fissures on the left may not be left lung morphology, because then you will have to look at the relationship of the pulmonary artery with the upper lobe bronchus. Okay, so the left upper lobe bronchus is below the pulmonary artery, so that is called hip arterial, and right upper lobe bronchus is anterior to the pulmonary artery, that is called aparterial. Look at the CT scan, and then you will see how they are oriented in a normal person. If you still have doubt, you should have my email. Shoot me an email and we can talk, and I can show you examples. I have really nice examples of different left and right morphology. But what we saw here on the X-ray is this is what we commonly see, and this is what they ask in our American Board of Radiology. So I'm writing questions for last 9 years. So we asked there this bronchus. So this is the left upper lobe bronchus, and that lies below the pulmonary artery. So this is what you see nicely on the lateral X-ray, and the right anterior is yeah. So this part is like, this is the right upper lobe anterior to the pulmonary artery. It's a little bit hard to see, but this one you can see the outline of the pulmonary artery, and below is the bronchus. So this is the left pulmonary artery and the bronchus. So this is hip arterial, that is below the bronchus, is below the pulmonary artery. I hope it helps, but we'll have to look at CT scan to understand it better.
Yes, sir. Thank you so much for patiently answering even the last question. It was just amazing to host you today as we celebrate our 800th webinar. I'm happy to share almost 400 participants joined us today as we celebrated the session on one of the most basic radiographic examinations that we perform. Even the planets have joined in with a celestial parade to mark this occasion. So it is just something coincidental, but we are happy to share that. Thank you so much, sir, for this wonderful session, and we hope to have you again on this platform in future as well. So thank you.
Okay, somebody is asking my email ID, so I am